Cheryl. In little kids, preschoolers under the age of 5 or 6, asthma is really hard to diagnose. We kind of say, looks like a duck, walks like a duck, let's treat it like a duck and see how we go. In other words, we give a trial of asthma treatment. But there's lots of wheezy preschoolers that don't actually go on to develop asthma. So it's a little bit of a glimmer of a light to hold on to, a bit of hope. Those kids in your centre that have been diagnosed asthma under that age may not actually have true asthma. But for the purposes of today, we're going to talk about this thing, asthma. So what is it? As you can see from this picture, these are the lungs. If we go into the lungs, we find the airways. In children, you can have maybe 30,000 of these, and some of them can be as small as a single strand of hair. If we were to pull one of these airways out of this picture and have a closer look, we get something like this. This is the airway of someone who doesn't have asthma, or somebody who does, but they're really well controlled. There's nothing squeezing this airway, there's nothing blocking this airway. These represent the muscles and they're nice and relaxed. I don't have asthma. If I was to breathe something in that's in the air, like pollen or smoke or something like that, nothing much happens to me. I just get on with my day. A person with asthma has a really sensitive lining on the inside of their airway. So when they breathe something in, that airway overreacts to that thing in the air. And the first thing that happens is these muscles start to squeeze. You can see that's pretty hard to breathe through now. You're going to start experiencing tightness in the chest, cough, wheeze, shortness of breath. A child might say, my chest hurts, because they can't verbalize what they're trying to get across to you. That's problem number one. Problem number two is all the swelling and mucus that builds on the inside of the airway, the inflammation. So because we have two problems, we have two medicines. And this is really fundamental to grasp as far as asthma management goes, that we know the difference. Because in early childcare, you want to make sure you're treating this thing with the right inhaler. So the first lot of medicines we're going to talk about is the relievers. Relievers are generally blue, and there's some that are grey as well. So we're used to Respigen, Ventolin, this kind of thing. These are really important inhalers because they're first aid. So it's like a bandage on a gaping wound. This is the bandage, but it's not necessarily the treatment. It's really important, works super fast within a few minutes and wears off about 4 hours later. Now the job of this fella is when we give it, it instructs the airways to relax these muscles. So basically opens up the airways. You could give this medicine till the cows come home and you will never ever treat the inflammation and swelling on the inside of the airway because it doesn't know how to do that. So it's important, but it is not a treatment. We know that if we overuse this medicine, eventually it will make all of this worse, and it means that our body over time would stop reacting to it. It would just ignore it. So although it is important for first aid, it is not a treatment. Our tolerance limit for reliever medicine as to how we deem whether asthma is well managed or not is if you need this more than twice a week, we would consider your asthma not well managed and you're at risk. So I'm sure that's might be news to a few people who are watching this because a lot of people think the tolerance would be a lot higher. So what that draws to your attention is those families in your centre perhaps who don't understand this either. And they'll say to things like, could you just give him a puff before he goes out to play and before lunch and before morning tea and if he's wheezy and also just cause? Well, it's not used like that. We wouldn't put a bandage on your arm just in case you get a cut today. We bandage up the cut once it's happened. This is a response to treatment, a response to symptoms medicine. It is not a medicine that we use just in case. All those just in case doses are going to add to how much your body's getting and then it may not listen to it in an emergency. The other situation may be that mum and dad come to you on a Monday morning to drop off their child and they're very tired, they've been up all weekend, yawning, can't wait to go home and have a nap, and you inquire a little bit more and yes, Johnny's been up all weekend with this asthma, it's been terrible, and actually they've been giving this around the clock pretty much. That is a huge warning bell. That child needs to go and get medical attention. That's quite serious. And even if they're a little bit better on the Monday, they still need to be reviewed because they've needed this more than twice a week over the weekend alone. There might also be a child who's been in hospital on the weekend and now they're home. However, is that child medically fit to be at your centre? Because just because they've been discharged doesn't mean they are completely better, and asthma has this horrible habit of cycling back up again sometimes. So you want to make sure they've been medically cleared properly by their GP as well. So there's a few scenarios there where you can see that the tolerance for this is really low, and we need to make sure that there's a lot of education behind this, because you probably will encounter a little bit of resistance from people who just don't understand. So send them to us and we will help, we will assess and we will advise, and it will all become a lot clearer. So preventer medicines are what we use when we feel that the asthma needs proper treatment rather than just a bandage. Flixitide is what you might have heard of. This is a twice a day morning and night medicine. It works over time slowly. This will not work in an emergency. It chips away at all the swelling and inflammation inside the airway. It doesn't do anything for relaxing the muscles, so it can't help you breathe quickly. But over time it will work to clear it all out. This person who's using their preventer well, and as they should, will eventually end up with airways that look like this. So if this is me day to day without asthma, let's think of a person with asthma unfortunately has a little bit of a glitch in their system, and they need this in their life to have airways the same as mine who I don't have asthma. Just part of their life. But in little ones, as I said at the beginning, it's more of a trial. So preventers are not something you should see at your centre. They are something to be given at night and in the morning, but not in the centre, unless you've agreed to give one of those morning and night doses. It shouldn't be something given in response to symptoms during the day. So, correct technique on how to use the inhaler. We want to use a spacer. Now the reason for using a spacer is you can see from this picture here, if we don't use a spacer and we just use the puffer, you will get probably less than 20% to your lungs, even with perfect technique. When we use a spacer, that increases to about 70%. The reason for that is when we pump the medicine into the spacer, all the heavy particles will fall out. The rest of the medicine will hover around in here. I say to the kids it's a bit like astronauts floating in space, waiting, captured in there for the person to breathe them in. So sucking them down into their lungs rather than trying to squirt them. Because when we just squirt that in, we might as well spray paint our tonsils. So it takes 6 breaths to empty all that out of there, all that air out of there. So the correct technique, take the cap off, shake it nice and hard to mix the aerosol and the medicine. If you don't, you might just pump aerosol. Into the spacer, into the child's mouth, 1 puff, 6 breaths. Not like a train and not dramatic, just normal breaths. After those 6 breaths, if another pump is needed, shake again. In the time it took them to do those 6 breaths, this may have settled. 1 puff, 6 breaths. In an emergency, it's really tempting to just go, let's just get it into them. We can't do that. The reason for that is it's always 1 puff at a time. If we put more than 1 puff at a time in here, all the medicine clumps together, becomes heavy, falls out, and then we're wasting our time. Be patient, 1 at a time. So you can see then that it's a fairly simple technique, but we've just got to make sure we do it correctly in order to get the medicine in. Make sure this goes through their teeth and they get a good seal with their lips. So, using the spacer and puffer in an emergency. So one of the first things we want to do here is assess the severity of the situation. Is it mild, moderate or severe, by looking at their symptoms. For mild symptoms, we want to start off with 2 doses of the reliever inhaler. That's 1 puff, 6 breaths, twice through a spacer, and then wait a few minutes to see how things go. However, if things are more moderate or severe, start off with 6 doses. If you've given 2 and it hasn't really helped after a few minutes, then give an extra 4 up to that total of 6 and then see how that goes. If not improving after, say, 5 or 6 minutes, then you do need to call an ambulance. You need to remember that the blue reliever or the reliever you're using, it should work. And if it hasn't worked, then this is serious because that's generally all you've got with you. You need to continue to give the reliever inhaler 1 puff, 6 breaths, 6 times every 5 or 6 minutes until the ambulance gets there. And in this situation, you will not overdose somebody by doing this. It will be what keeps them alive. And then we want to keep on monitoring to see how things are going because asthma can cycle up and down. Remember, it is much safer to call an ambulance and have it on its way than not and have a catastrophe. So it is better to act than not act. Is the child mild, moderate or severe? Mild is the kid with a bit of a cough, feeling a little bit under, miss, I need my inhaler, my chest is a bit tight. They're not in masses of distress, but they're brewing. They'll be mild. If it was more moderate, coughing, we're seeing tug here, we've got ribs pulling in, they can't speak a full sentence, they're, miss, I don't feel well, and they're struggling. This is more moderate or severe. You go straight in with 6 puffs. 1 puff, 6 breaths, through a spacer, and you do that 6 times. After that, they should be better. If they're not, call an ambulance. The take-home message is the blue inhaler, the reliever or the grey one, should work. If it does not work, this is a massive problem and we need to do something about that. Every child in your centre should have an action plan. They look like this. It tells you what to do when. They need to be filled in by a doctor and they're specific for every child. So you follow through the traffic light system to ascertain what to do when. It's really important that every child has one of these because this is what you will follow in an emergency in order to give that child the correct care that they need. Every child should have their own reliever and spacer. These are single patient use. So if you have had to use your emergency one on a child, it needs to be replaced. There's a risk of transmission if you don't. It is not recommended to even wash these and reuse them, not at all. And you should also have a policy in your preschool about, where's the line for sending kids home who you're worried about. You can refer back to this policy if you feel that you need to. I'm really sorry, but this is our centre policy. We want to look after your child and make sure they're safe. Could you please take them to the doctor and get a review and then they can come back. If you've got it in a policy, then you can refer back to it. We've got sample policies that we can send to you to help with this too. And they should all have their doses recorded and mum and dad should be aware of whether you've given it or not, which I'm sure you do anyway. Make sure you keep an eye on the expiry date on these as well because they do expire, especially if they're not being used very often. Triggers. You can see from this chart that there's lots of different things that can set off asthma. Cockroaches is one that lots of people don't know about. There's mold, there's cleaning products. What do you use in your centre? There are cold air is another one. Maybe that cold day is a day to play inside for that little asthmatic and let's not expose them to that trigger. If they need to go out, perhaps you could use a scarf, a loose scarf across their nose and mouth just to warm the air before it goes in. Make sure it's cotton, not wool, and that it's clean. If they have a significant dust mite allergy, potentially not such a good idea. And just being aware of, even things like emotions can set off asthma. We're not going to say to those kids, hey, there's to be no crying, no laughing, you're just to be a very serious child. We're not going to stop them from being normal human beings. What we're going to say is, if we know these are triggers and you have asthma, I'm just going to watch you a bit more closely if you find something hilarious, or if you're throwing yourself on the floor and having a big paddy, I'm just going to watch you a bit closer because this might spark an asthma attack. And this is just about being aware. So just a quick word for any centres or schools that might have a group of children who are 12 and above. There was a change in the guidelines recently where we used to recommend the blue inhaler as step 1 for just treating an asthma attack. We've now realised that that kind of can cause other issues. So for 12 pluses, the first step now is more either take a preventer dose every time you take a reliever dose, which most people wouldn't do, or there's a medicine called Symbicort. Now in New Zealand, this is the only one we can use at the moment, but I'm sure there will be others. And this medicine in here is both a steroid to treat the inflammation, but also a reliever to provide immediate relief. This is the only combination. The medicines in here are the only ones that work straight away to address the problem at the time. There's other combination inhalers like the purple one, for example, that will not work in an emergency because it doesn't work quick enough. The medicines in this one do work quickly, so you can use them in an emergency. So you might get kids 12 plus who say, this is my reliever, and you can be confident that yes, it is used as a reliever as well. But the way that this is used is you take the lid off, you hold it upright, you turn it all the way one way, all the way the other, exhale away from the device, tip it up, put it between your teeth, and big breath in. You breathe in as hard as you can for as long as you can and hold your breath for 10 seconds. You can watch a proper video on this, which is on our YouTube channel if you want to go through that technique in more detail. But the problem is if you're having a significant asthma attack, this may be very hard to pull a deep breath in. So it is recommended that you have an emergency spacer and puffer available for that child who may be on this, and that's all they've got, because we can treat an emergency better with an puffer and a spacer. However, you may see a few kids on Symbicort. If they're just treating mild symptoms, it will be absolutely fine. If there's any problems, any issues, any questions you've got, please give me a call or email us at Asthma Waikato, send us a Facebook message, whatever works for you, and we will do our very best to help you with any questions you've got or any feedback you have on these videos. Okay, all the very best. Bye.